very good morning to professors, doctors, and fellow colleagues. I'm very honored that I am here today for breakfast at UMHealth. I'll be your chairperson or moderator for the first session. I'm given the honor to introduce the speaker as well as the topic for this first session. So the speaker for the session today is Dr. Leong. Dr. Leong is a graduate of IMU, and he actually obtained his Masters of Internal Medicine in University Malaya and also completed his hematology training here. He is currently a clinical hematologist and lecturer in UM since 2018. And today he is going to present to us a very interesting topic entitled The Current Landscape of Management in Acute Myeloid Leukemia in UMMC. Just a little brief intro about acute myeloid leukemia. Acute myeloid leukemia treatment has always been a backbone of an anthracycline and cytosine arabinoside for quite a number of decades. But there are a lot of new discoveries in terms of its molecular landscape and also new paradigms of treatment. So Dr. Leong will give us a foretaste of how we treat acute myeloid leukemia currently and perhaps a glimpse of future treatment paradigms. So without further ado, Dr. Leong.
Okay, thank you, Dr. Edmund, for the kind introduction. Good morning. I am Dr. Leong. I'm from hematology team. I would share with you what's the current landscape of management in AML in our center. Let me share my screen now. Contents of today 25-minute session will be including introduction, diagnosis and investigation, management, some novel treatment and approach, as well as just a brief mention of APML. You'll be incomplete without talking about APML in acute myeloid leukemia, really. I'll start off with a case scenario one. We'll go through the case and then we'll see how things are handled actually in our center. This is a 27-year-old lady who is a baker. He was fairly well until 1 week prior to presentation, just generalized unwell with some petechial over both lower limbs. She actually had a consultation with a family doctor first. Over count done, noted that there's actually low red cell, mild anemia. White cell was normal, but platelet was very low as well. Peripheral blood done in another center showed that there's a blast of 40% despite the white cell count that was normal. So I think that boils down to a question when a young patient comes in, with symptoms of some bleeding, a bit unwell. White cell is normal, but there's a lot of blast. Are we thinking about acute leukemia? I think mostly of us would say yes. So acute myeloid leukemia is actually very aggressive blood cell cancer that arises from myeloid stem cell, as you can see highlighted here. It's an aggressive cancer, no doubt about that. How common is it in Malaysia, really? When we are looking back at the data a few years back, the incidence rate was about 2.8 per 100,000 population, and there's slight predominance in male. So when you look at the ranking of common cancers in Malaysia, you can see that both in male and female, leukemia is actually one of the top 10 among all, really. Yeah. And one thing about AML is actually the median age of diagnosis is 68 years. So it wouldn't be wrong to say that, most acute myeloid leukemia is sort of age of elderly disease. And you can see that incidence actually increased with age. You can see this graph that was actually taken from the Sarawak, our very local study that, as age increase, you can see that there are more incidents of AML, both male and female, really. So that brings us to the next issue. It's not an easy task to really handle AML in elderly, because we know that AML is an aggressive disease, therefore we need aggressive treatment. But that makes a lot of elderly not probably not a good candidate to undergo the conventional chemotherapy. Presentations of AML are actually signs and symptoms that are related to either anemia or thrombocytopenia. They can with pallor, reduced effort tolerance, palpitations. Sometimes they may have bleeding episodes such as presented in this case, spontaneous bruises. And because most of the white cells actually consist of blasts that are ineffective of mounting any immune response, so they do come with infections. Those who have very, very high white cells, over 300, 400, come in with symptomatic hyperleukocytosis or what we call leukostasis. Some of these patients may have tumor lysis syndrome because their white cells are very high, aggressive. And in acute promyelocytic leukemia, they may present with DIVC as well. Yeah. How do we confirm the diagnosis when we look at the patient? I mean, the peripheral blood film is not a diagnostic tool, really. It just tells us that the acute leukemia is probably there. So when the full count machine or the peripheral blood film say that there's circulating blood cells or there's unexplained cytopenia even without blood cells, also one of the differential diagnoses is always acute myeloid leukemia. But do bear in mind that not every full blood count with blast equal to acute leukemia. Sometimes in very, very ill patients, septic shock, DIVC also, they may have this blast, probably 1 or 2%. The other condition, for example, myeloid dysplastic syndrome, myeloproliferative disease, they can also have small percentage of blast in their full blood count as well. Okay, so the definitive diagnosis, the way to go as of now is still to do a bone marrow aspiration and trephine biopsy already. And the bone, we need to demonstrate that there is bone marrow infiltration of more than 20% of blast. I think this has been conventionally held true since last time. Leukemic cell must be myeloid in origin to say that it's AML. So there are different ways to do it. Looking at the cells, whether they are aurochs or not, cytochemical stain, as well as nowadays we're using flow cytometry to look at markers to say that it's myeloid or lymphoid blast. Yeah. So after we have done a bone marrow examination, that's probably the beginning, we'll say, not too difficult part. What next actually? These specimens will actually be sent to the hematopathology lab for further processing. And these are where all the hard work actually go in. So the bone marrow aspirate will be stained, the fragment will be being looked at under the microscope for morphological as well as to go for cytochemical study. So these are no easy job really. Going through the stains, the slides, quite a few of them, and then going through many fields, high power fields to look at the specific structures. And this is one of the peripheral blood film just to show you that how they prepare. And then these are the things that we put under microscope to look at. So under the microscope, well, if the blasts are abundant, you probably can pick them up really fast. But then you need to actually go for other things, for example, cytogenetic studies to look at the karyotyping. So when we at the receiving end receive the report, we would actually look at this very nicely arranged chromosomal report already. But in actual sense, when these are being done, they need to culture the cell, they need to tease out all these chromosomes. Things will be in a very messy situation, and then they need to rearrange. So there are a lot of work going on in the lab. Yeah, that's very important. Our lab support is very important, really. Okay. On top of all these things, there are more specific things to be done. For example, molecular genetic studies, flow cytometry analysis. This is just an example of what are the molecular markers that we have in our lab, and then flow cytometry, interrogating the cells to see what markers they have to decide whether these are really myeloid leukemia, if so, what sort of lineage, things like that. So this again is actually probably 1 hour topic by itself for flow cytometry analysis. We have the machines here in and our hematopathologists are doing very great work. Yeah, I should thank Dr. Mazia, Dr. Hany, and Dr. Paul. They are always ready and to help us with the bone marrow report, and happy for discussion. So yeah. So classification of AML, traditionally, we have been talking about this FAB classification, M1, M2, and 3. These are really based on what we can see the morphology of the blood under microscope. We are actually still adopting this nowadays because this is something that could be given very fast, with the morphology. I can say probably this is M4 and 5, things like that. But things move on. We have WHO 2016. In fact, we have the latest WHO 5th edition of classification just about 2 years ago. There's changes. It's actually moving towards morphology classification, towards genetic abnormalities, and if really can't, then this differentiation of morphology. So these changes from morphology to genetic abnormalities, it sort of represent that the evolution of how we understand acute myeloid leukemia, and it also presents breakthroughs as well. Let's have a look at the AML classification. I'm not going to bore you to go through one by one, but just look at these two big groups. This one, AML with defining genetic abnormalities. So now we classify them according to the genetic abnormalities that we could detect. For example, NPM1 mutation, for example, CB, SECBA mutation. Okay. In fact, with the new classification, the European lead of leukemia actually say that, because these defining genetic abnormalities are, they will transform into leukemia even before they are leukemia actually, even before the blast is at 20%. So as of now, if you can demonstrate that there is this genetic abnormalities as listed here, even the blast with 10% in the bone marrow would say that it's acute myeloid leukemia, and start treatment straight away rather than wait. Okay, but of course there are times that you can't find these genetic abnormalities. So there is still a classification that put there defined by differentiation, whether is it myelomonocytic, whether is it without maturation or minimal differentiation, etc. Yeah. So for the later category, you still need to go by with plus of 20% more. Okay. So after we have classified what sort of AML it is, the next thing in our strategy of management is actually to re-stratify them, whether they are favorable, they are intermediate, or adverse risk. Why we want to stratify this patient? This is mainly for long-term management, really. So if patients have certain genetic abnormality or mutation, some that are good, some that are bad. Not all mutations are bad, really. For X-Men mutation, some are good, some are bad. So those who are categorized as favorable, a good one, they perhaps have no need to go for stem cell transplant in future because the risk of relapse is very low. Whereas those with intermediate and adverse risk, the risk of relapse is high even if we have pushed them into remission with treatment. So generally, they will need some form of allogeneic stem cell transplant in the future. Okay, yeah. So the management for acute myeloid leukemia, the aim is actually to induce remission. If the patient is medically fit, really, the aim is try to, as hard as possible, to induce remission by treatment. But before starting on patient with chemotherapy, really, we need to decide how well the patient is. So we have this ECOG classification to see how well patient can carry themselves, what sort of medical comorbidities they have. We have to do Hep B, C, retroviral screening. We also have to do an echocardiogram. In fact, as Dr. Emmon mentioned earlier, the backbone of AML is anthracycline. So that can cause cardiomyopathy. So assessing cardiac function is really important. And that's where we need our cardiologist colleague to really check for the heart function. Not to mention liver and renal impairment also plays a role sometimes in deciding the regimen and also adjusting the regimen. Okay, so the induction regime traditionally and conventionally and now is still cytarabine plus daunorubicin. 7+3 just means that one go for 7 days, one go for 3 days. This is a very, very highly toxic chemo regime that will usually cause almost a month of severe cytopenia in patients who receive this type of chemo, and they actually have a high risk of having life-threatening infection or even bleeding at times as well. So with that, there are supportive and adjunctive care, for example, very potent anti-emetic medication. The cytopenia part, we really need to give blood product transfusion. And this is where our blood bank colleague actually come into play, that they will provide us, blood products with special requirement, for example, whether irradiated or leukodepleted, single donor bladder, etc. During this 1 month treatment where they stay in hospital, they usually will require a lot of blood product transfusion, more than one person that may receive during an accident. They need quite a bit of blood product transfusion. And because the risk of infection is high, whether bacterial or fungal, they will need prophylaxis therapy. And if they have fever, from the treatment with broad spectrum antibiotic is really needed for them. Yeah. So yeah, like I mentioned, AML, cytarabine plus doxorubicin is really toxic. I describe it as like atopic blast, really clear out the bone marrow and cause a lot of myelosuppression. Yeah. So I talk about leukostasis as well as tumor lysis syndrome in AML. So I'll just go through them briefly. I think a lot of our audience will be very familiar with tumor lysis syndrome because it occurs in many types of other tumor as well. So usually risk is high when white blood cell is more than 100. When they actually die in large cohort, then they release a lot of byproducts that can cause renal failure, shutdown, etc. And prophylaxis is still the best way to prevent it from happening. Hydration and allopurinol. If really patient go into tumor lysis syndrome, we need to collect the electrolytes. We have respiratory which actually would help in tumor lysis syndrome with really good effect. But if all else fails, then we need our renal colleagues to help us dialysis. Yeah. The other medical emergency is leukostasis, where patient has very high white cell with symptoms of clinical findings that could be due to tissue hypoxia. It's more common in AML as compared to ALL really. What happened is that because of the high white cell, the blood viscosity is increased, so they cause sort of obstruction. And then you have hypoxemia, and then you have issues with cytokine release from blast also. Typically, they may present with confusion. Sometimes they may have dyspnea, and on the X-ray, you may see alveoli infiltrate. The treatment for leukostasis is actually to bring down the blast counts as quickly as possible. So the way to go forward is actually to start chemotherapy to take off this blast actually. For those who are not eligible for chemo, then leukophoresis and hydroxyurea, but this is not a definitive way. This is just to buy time for definite management to go on. Okay. So after we have given chemo already, the next thing to do is actually to respond, to check on the response, how good the patient is. How do we check response? Again, we go for bone marrow examination again after counts recover. This typically happened about 4 to 5 weeks after the first induction chemo. We look at the hematopathologist will look at the slide and then decide bone marrow blast is less than 5%, etc. For this thing, we call it remission, or rather the blast is still a long 10-20%. There's resistant disease. Oh no, we have to go for something else. Okay, so after the first induction chemo, seems like patient gone through a lot of ordeals, and patient gone through remission. Do we call it day already? Is it a better one already? I must cautious you, not really. The treatment for AML is something that is fairly long-minded. It's a long road. So with the induction regime, the first chemo, if patient attain remission, they actually will go for second induction chemo again. Okay, and then they go for about 1 or 2 cycles of consolidation chemo. And then from there, you can see how the risk stratification work. Whether if it's good risk, you don't need transplant, just surveillance. Where the high risk one, you need to go for stem cell transplant. But what about those patients who has resistant disease or refractory? They have to go for second line, salvage chemo or something that's stronger, recheck response, and then decide what next for them. If it's still resistant, you have to go for other treatment really. So after having a general overview of how we treat AML, let's go back to this Miss K, who is a baker. So the bone marrow examination was done. True enough, there is more than 20% of blood cell. The final diagnosis for her is AML with this SECPA mutation. So she underwent first induction chemo with daunorubicin and cytarabine. And luckily for her, actually, she just had mild febrile neutropenia recovered. And the bone marrow examination after the first cycle chemo was good news, she's in remission. So she went on to receive second cycle induction chemo and then recently got in consolidation chemo. Well, you would think that things should be quite okay, settled already. Unfortunately, with this third cycle chemo, she actually developed very bad neutropenia until she requires intubation. I'm just showing you the one of the chest X-ray to see, to illustrate how bad that infection was. She required ICU stay for a few days, but fortunately, with the support from ICU team, she actually extubated, came well. So for AML per se, for each chemo is sort of a series of skirmish or battles. You need to go through, the patient need to go through a few of them to really become, to be sort of in remission. Why do we need to go through such a few line of such sadistic chemo? Reason is we know that if it's just first chemo and then patient remission and we stop, very soon the disease will actually relapse. We need to go through this few cycles of induction as well as consolidation to make sure that disease is in real remission. Okay. We talk about those patients who are fit. How about those who are elderly that I mentioned in the earlier of the slide? Because this AML, after all, occurs in a lot of elderly patients. So you have the medically unfit or those who are really frail one. How do we do them? How do we treat them? So the medically unfit patient would be, the aim is a bit different. We still try to achieve remission, but the important thing is try to extend survival and improve the quality of life. Traditionally, we use this hypomethylation agent called azacitidine for disease control. But currently, there's something new, what we call oral, what patients call oral chemotherapy, which is venetoclax with azacitidine. I'll go through this in a while. Whereas a very frail patient, no, they can't go through even such azacitidine or venetoclax medication. They are totally really unwell. So for them, the aim is more of palliative, we want to improve the quality of care, reduce some symptoms, and then, make sure they are peaceful, well, during their final stage of disease. Okay. So some of these patients may really go for alternative treatment, which we have no objection. Yeah. We talk about elderly patient, medically unfit patient. One of the advances is azacitidine. This has been here for many years already. It is actually more to disease control rather than to achieve remission. You can see that from the study, the overall survival, well, there is a modest increase from 7 months to 10 months. There's a 3 months increase. Some of you will say, this is nothing much really. Okay? But do remember that some of these patients, 30% of them do achieve remission. But the aim for when starting azacitidine is really more for disease control, not for remission. But now with the new medication, what we call the oral medication of venetoclax, this BCL2 inhibitor, in the horizon, things are changing. The use of venetoclax plus azacitidine actually has superior OS, overall survival. You can see that from supportive treatment of 7 months, now things are becoming 15 months, more than a year already. And the rate of remission is actually higher. Previously, we are talking about near 30%. Now we are talking about 60+%. That means that every 2 in 3 patients may achieve remission, and they would probably be transfusion free also. But do bear in mind that these are actually studies data. Sometimes in real life, things may not be as glory as this. And toxicity-wise, it's not to say that with oral medication, things are going to be very mild. No, you still have febrile neutropenia, you still have very severe cytopenia that require admission. And sometimes things will be going downhill with very bad infection really. Let me present you another case, a scenario 2. It's just an elderly patient, a 78-year-old man who is a doctor in private practice, but the premorbid not too bad is ECOG1. He's actually having bronchiectasis on oxygen. Despite that, he's still practicing, and I think having a thriving business in private practice really. there's an incidental finding of high white cell during an elective minor operation, and that brought him to us for further evaluation. When on arrival, the red blood cell was low, anemic, white cell was high, 32, and platelet was normal. Peripheral blood short, numerous blasts. We did a bone marrow examination and showed that there's AML with 68% blast really. So if you look at this data, look at this profile, traditionally a 78 years old man, you probably wouldn't be fit for any conventional chemo. And most of the time, the past would have said, conservative management or maybe azacitidine to prolong the survival. That's all. Okay. So what would you do? Whether would you give induction chemo, DA3 plus 7? You say, it's 78, but it's fairly fit. Maybe we can push the limit. Or we try azacitidine, something in between. Maybe use something azacitidine plus venetoclax. Or is it palliative care, 78 years old, or enroll into trial? So you can see the option. I put A, everything here, not B or C or D. I'll tell you why. Actually, there's no right or wrong. It really depends on the assessment of the patient at that point, and also the discussion with the patient of what options we have and what the patient, and in Malaysia setting, what their family also want. We need to respect as well. So we talked to them, and then the team decided, and then the patient decided to go for this novel therapy of venetoclax and azacitidine. He did have cytopenia, he did have infection that required admission, but nothing major. And to, I think, our pleasant surprise, he actually went into remission after 2 cycles of therapy. I'm happy to report that I look back at his data, 1 year into therapy, now he's actually still doing well, still walking about really. Okay, so yeah, with novel treatment, there's a breakthrough in paradigm treatment for elderly AML and those medically fit. Okay, but of course, I'm presenting a very good case to you. I must say that not all cases are as glorious as this one. We still lost patients, elderly patient, medically unfit patient, despite so-called novel therapy because of infection, because of very severe cytopenia already. Okay. I must mention that hematopoietic stem cell transplant is one major component in acute myeloid leukemia. However, this is a big topic by itself. So I just want to mention that we had actually a 36 years anniversary celebration of recent. Yeah, these are the pictures that was done during the taken during the event. Okay, I think I have very limited time already. Just let me go through the novel approaches very quickly. Nowadays, AML, we talk about molecular markers, and there are some of these that are targetable by therapy. So the new things, not really new, but something that people are more aware of is mutated FLT3 ITD markers, that there is actionable drug against this. By adding this onto the induction chemotherapy, patient actually have better outcome really. So we have things like, not really we, but in market you have things like ivosidenib and gentuximab therapy as well. These are all add-on therapy to those who have molecular markers. We are also talking about novel approach. I think measurable residue disease, MRD, is not something that's alien to a lot of audience. In AML also, we are moving towards that. So hopefully, other than just looking at bone marrow to say that the blast is less than 5%, in future, hopefully we can actually use flow cytometry, employ this to actually tell us, whether the remission is really deep. Because in morphology, you can just look at counts of blast. Sometimes you may miss certain part because bone marrow is essentially a blind procedure. Whereas flow cytometry is actually something that is more objective, really. It can measure those residue disease that can be really picked up. It gives a definition of a deeper response. And in future, probably PCR as well, which is already been done in AML by its team already. I did say that I want to mention about APML. Acute promyelocytic leukemia is a subtype of acute myeloid leukemia, which has very good prognosis, provided patients survive the first 2 to 3 weeks. I mentioned they actually present with DIBC. They can have very fatal bleeding, including ICB or GI bleed. They can have thrombosis also. therapy used to be ultra with chemotherapy, but things are moving. In fact, now people are moving towards, clinicians are moving towards novel therapy of chemo-free regime using ultra with arsenic trioxide. And there will be, looking at the reports, things are very better. You have less toxic fever there during induction. Okay. So these are something that's very attractive, especially to patients when you say there's chemo-free. Yeah, people are very excited about it. Okay. So I would like to say thank you to my team. This is our small team here. To our supporting team, especially the hematopathologists, blood bank, staff nurses, and as things go by, I just want to conclude with this slide. In the past for leukemia, things have been doing like this. Looking at this World War II picture, people are doing coupled bombing. Just give a chemo that kills everything, whether good or bad, go off. Proceeding to nowadays, people are using a bit more precision bombing, but we are still giving a lot of bombs with undesired side effects, really. In future, probably the novel treatment will be actually going for very accurate, targeted bombing to take off the leukemia. That will be the prospect. That will what we hope for in future. And that's all from me. Thank you.
All right, thank you, Dr. Leong, for the talk. And in the interest of time, we will go to the next section. If any questions, please, you can ask your questions in the chat box. Thank you.